Good afternoon and welcome everyone. Thank you so much for joining us today. My name is Meg Beyer. I'm part of the Managed Care Technical Assistance Center, otherwise known as MCTAC team. I'm thrilled to be joined today by some of our partners from OMH who are going to walk us through the content for today's webinar on COVID-19 program and billing updates for PROS programs. So a few logistics before we dive right in. We are recording today's presentation. So the recording of today's presentation and the slides are going to be available afterwards. They'll likely be emailed out to everyone as well as posted to the MCTAC website. So if you are looking to share these with your colleagues or just listen in again, review the information, and refer back to what's presented on today, fear not, you're totally going to be able to. We're going to share the slides with you and the recording shortly after we conclude. The other thing I want to encourage, for those of you who have joined our MCTAC webinars before, you know that we collect a lot of questions and encourage you to chat them in throughout the entirety of the webinar. So today's webinar is a little brief, but we do hope to have time at the end to address some of your questions. So I would recommend that you use the chat box functionality, which can be found to the right-hand side of your screen. If you select the host, if you can chat in your questions to the host, my colleague Kevin, who is our MCTAC admin today, will be collecting them all in a centralized document so that we can review them as easily as possible towards the end of the presentation if time permits. And lastly, I just want to thank our presenters today who will be joining us. We have Nicole Haggerty, Liam McNabb, Peter Barnett, and Lee Aiza. So thank you everyone for joining us. And with that, I'm going to ask Nicole to get us started.
Thank you, Meg. We can go ahead and advance the slides. Thank you, everyone, on behalf of the New York State Office of Mental Health for the important work you are all doing in this incredibly challenging time. We can move on. Given the nature of the COVID-19 pandemic, mental health providers have had to quickly adjust to dramatic changes in staffing, service delivery, and outreach. Community behavioral health providers offer a critical safety net, maybe more now than ever. As such, OMH has worked with the Department of Health and the Governor's Office to secure waivers that allow providers to deliver services in new and flexible ways, including the expansion of telehealth. The guidance cited in this presentation was issued on April 13th. However, the billing and documentation relief you will hear about is effective as of March 7th, 2020, the start of the declared disaster emergency. Okay. As OMH relaxes documentation and billing standards, we do also expect that programs will continue to maintain quality services and continuity of care to every extent possible. We hope that the relaxation of billing standards also supports agencies in maintaining current staffing levels. We ask that providers continue to support individuals and ensure access to essential services during the disaster emergency. Okay. Essential services are services that are especially relevant in the current environment. Delivery of these services do not require updates to treatment plans, service plans, or in this case, recovery plans. Essential services are simply intended to support individuals' basic needs during the disaster emergency period. And with that, I'm going to turn it over to Liam McNabb to talk about how this affects providers of personalized recovery-oriented services or PROS programs.
Thank you, Nicole. And as you can see on the slide are a list of essential services that include medication, individual counseling and therapy, and crisis, of course. But number 6 is critical, especially when the crisis hit, the support of emotional and physical needs, as participants were told to stay home, and staying home is difficult for people as they isolate. For PROS especially, another service that we've heard a great deal about that participants need is relapse prevention. Intensive relapse prevention is part of the IR menu of services. and of course, wellness self-management. So learning and practicing coping techniques to stay healthy during this crisis is especially critical, and so this consistent contact with participants and talking through their needs is very important. Next slide. So PRO's program expectations at this time. And once again, as we outline the outreach efforts for this guidance, the efforts made are with the goal of consistent engagement for participants. And continued efforts should be made for participants you're unable to contact. I want to call your attention to the third bullet of engaging participants around assessing their needs and providing support, but also in addition, it's critical to make sure individuals have a list of important telephone numbers and local resources and a step-by-step plan for contacting appropriate stakeholders when needed. So as you all know, PROS is a predominantly place-based model, and right now participants don't have the luxury of coming into the program space to see staff and receive needed support or to see peers and others who provide support on a regular basis. So now more than ever is a time to identify and use natural resources and supports as much as possible, and helping participants ensure that there are natural supports near them and for them to use as needed is very helpful. And of course, for individuals enrolled in the clinic treatment component of your PROS program, medication management and clinical counseling should be available. And from what we've heard and talking to many of you in the PROS community, you guys have done an exceptional job in making sure that medication's available, and in many cases, making home deliveries to people. But once again, the outreach expectations here are with the goal of consistent engagement with participants. Next slide, please. So here we'll talk about changes in documentation requirements. IRP reviews are not required and may be postponed as needed. Providers may work under existing individualized recovery plans and provide additional services as needed. So in the PROS model, as many of you know, there's always been this flexibility with adding or removing services as needed, not only to meet someone's needs, but as their interests change. But now more than ever, especially with the example I used earlier, intensive relapse prevention is a critical service that can be added to someone's IRP as needed, and the flexibility is once again there. And the need for these additional services, which weren't already included in the IRP, can be done through documenting this in a progress note. But also, one thing to keep in mind as PROS, IRP planning is critical, as you know, but documentation in and of itself is a good opportunity to engage a participant. We're offering flexibility with documentation, but keep in mind that the participants' recovery goals are still important to them. So check in with them around not only their health and well-being, but their own goals as a way to ensure that they know that you think that their goal is important as well. And also, what skills can a person practice independent of staff and independent of the program space and between scheduled group services and individual services at this time? Next slide, please. For new PROS participants at this time, initial individualized recovery plans and assessments may be established via telehealth capabilities, and timeframes for the initial IRPs are waived. Admissions should be prioritized. We're hearing a lot of flexibility among PROS programs that have been very responsive to admitting new participants, and this, once again, is especially critical because people need this support at this time. Signatures and consent on required documentation can be obtained verbally and documented in the record, and this is what the telehealth guidance and flexibility allowed us to do remotely. And then assessments and, once again, the initial individualized recovery plan should be focused on a person's immediate needs and may include medication management, safety needs, and then engaging someone in services immediately, of course, is the priority. But once again, keeping admission of new participants into your program moving is critical for a variety of reasons, because there's a need and there's a need for other programs to work closely with you as they move people from their program to yours. Next slide, please. Suspension of utilization review. So your programs and your organizations may suspend, for the time being, internal written utilization review procedures that we normally require, and this is for the duration of the disaster emergency. And of course, you'll be notified at a later time when this status will change, and then you'll be expected to once again resume these practices from a utilization review perspective. Next slide. Program expectations and billing requirements. These requirements are in place, once again, for the duration of this disaster emergency or until such time as supplemental guidance is issued. And this new flexibility in service delivery and billing is not intended to establish lesser standards for provision of services and support. There's terrific work going on in the pros community, and we expect that to continue. And the goal, of course, with this guidance and this entire effort was to promote fulfilling basic care and support for participants, of course, based on need, but also a consistent revenue stream, which is dire and critical for each of your programs and agencies. And now I'll turn over to Leah Yates on the next slide to talk more about, or Peter Barnett, the billing requirements and how revenue will help your programs.
Thank you, Liam. This is Peter Barnett. I'm going to walk through the billing changes under this guidance, and just to reiterate, the release of this billing guidance reduces contact standards for the PROS program. It's really intended to stabilize provider Medicaid revenue during the disaster emergency, where obviously services can't be rendered in the same manner that they have traditionally due to social distancing, quarantine, illness, and other challenges that we're facing. So it's our hope that these measures will sustain provider staffing levels and preserve the capacity to continue to serve PROS clients during these extraordinary circumstances. So as I look at slide 12, during the COVID disaster emergency period, OMH is allowing for billable contacts that are outside of the existing consolidated PROS reimbursement methodology, or the PROS unit conversion method, which you guys are familiar with. So what that does is it allows for all telephonic individual contacts to be a minimum of 5 minutes to count as a single billable service, and telephonic group contacts to be a minimum of 15 minutes to count as a billable service, rather than rolling up through the traditional PROS unit conversion method. Let's advance to slide 13. We see under these revised contact standards, providers may bill Tier 1, which is rate code 4520, if they provide 1 to 3 contacts in a month, or if a client contact cannot be made in a month, a minimum of 2 outreach attempts per week with the corresponding documentation included in the client record. The provider may alternatively bill Tier 3, which is rate code 4522, if they're able to provide 4 or more contacts in the month. So that's a different billing construct than traditional, allows for these reduced contact standards to generate either a Tier 1 or Tier 3 claim for all PROS enrollees during the month of billing. If we could move to 14. Providers may continue to bill the clinic add-on. This is rate code 4525. And to do this, they must bill a Tier 1 or a Tier 3 claim as covered in the previous slide, and one of the contacts must include a clinic service. So it's important to note that the intensive rehabilitation 4526, and the ongoing rehab and support, which was rate code 4527, they may not be billed as add-ons to the base rate when you're submitting claims that are qualified under these revised disaster relief standards. The revenue associated with those add-ons was evaluated and included in making the decision as to the Tier 3 particularly and Tier 1 standards for billing in a manner that was designed to help bring providers to historical or average revenue standards. And I want to note that implementation of these revised minimum billing requirements does not prevent PROS programs from providing services and billing for PROS services to recipients as they had historically done. If those contact standards are met, then those rate codes and those bills are available as they were historically. And if I could move to slide 15. It's important to understand the requirements for billing modifiers for both telehealth and for claims under the disaster emergency. These modifiers are a requirement to appear on the claim. So here we have a few examples. If a service is still delivered in person and the existing minimum requirements are met, then there's no need to use a telehealth or disaster or catastrophe modifier for that claim. You submit it as you otherwise would. If a service is delivered via telehealth and the existing minimum requirements are met, then the GT or the telehealth modifier would be added to the claim. And then lastly, if a service is delivered via telehealth and the existing minimum requirements are not met, but the minimum requirements under this COVID-19 flexibility billing guidelines are met, then you would add the GT and the CR modifier to the claim. So the PROS program uses a GT modifier for telehealth, I believe. There is a reference document on the OMH guidance on COVID-19 webpage. That's entitled Telehealth Modifier Use for OMH Licensed or Designated Programs. The link to the guidance page is in the guidance documents as well as this PowerPoint. There you'll find a compendium of all the telehealth modifiers at the rate and procedure code level, which you can use as a guide for billing. So I want to note for providers that, again, the intention here is to preserve adequate and historical levels of revenue for the PROS program. OMH is adding the CR modifier to identify claims that are submitted under these reduced standards, and we are reserving the right to evaluate claiming and revenue during the disaster emergency period. We will look at individual providers to see if that revenue is in line with what they have historically claimed and received, and reserve the right to recoup substantial windfalls against historical revenue levels or against actual costs. That's not the intent of this program. We're trying to support providers through this difficult period and allow for billing in what would otherwise be a very challenging environment. So with that said, I think we'll see the balance of the time, and I'll turn it back over to Meg to moderate specific questions. Meg, you still with me?
I am. I'm so sorry. I was double muted on that time. My bad, everybody.
Okay.
Here I am. Yeah, sorry about that. I'd asked two questions. So just wanted to say we've gotten a ton of questions in, and I want to thank everybody for continuing to send them in. We're collecting everything, and we're going to send it to the state. So even if we don't get to address your question on live, in live time, just know that the state will receive all the questions that are chatted in. So the first question, diving right in, is if we could just have a refresher, I think, on when the start date was for the guidance. When does the guidance start as of?
Yep. Hi, this is Nicole. So the effective date of the documentation and billing relief guidance that has been outlined in this presentation is March 7th, 2020.
All right, thank you. The next one, so what is the guidance for recording participation time, like the in and out times? Do these still need to be recorded?
Peter, you want me to take that one?
Yeah, I would defer to you, Liam, on whether or not you want to continue to record program participation time.
Yeah, and I think the question is related to the calculation of the PROS unit, which has been asked quite frequently, and so you can still record the service duration. So if you have a 15-minute one-on-one service, even if it's remote, the service duration is what you're using in your system to generate the PROS unit. So this is different, of course, than if you had program participation time on site, people signing in, signing out. You do the math at the end of the day by looking at the PROS conversion chart. Here you're using the service duration, whatever that duration may be. And so once again, the example I used is if it's a 15-minute service, you'd enter that into your system, and your system would calculate a PROS unit, and it will over the course of the calendar month.
Great, thank you. Okay, I think our next question, in regard to the relaxation and utilization reviews, would that also include chart reviews for compliance?
This is Liam again. I'm not sure. It sounds like they're asking for requirements beyond the IRP.
Mm-hmm.
So I think that's one we'll have to revisit. But I would encourage.
Okay.
Yeah, I would encourage people, if they have specific questions around aspects of the case record and/or the recovery plan, send those in, and we can address those as we go.
Great, thank you. Okay, so do providers still have to complete an immediate needs plan on the date of admission for new clients?
Yeah, as best as you're able to. Certainly we recognize all the challenges and barriers that are in place now, and there's so much happening remotely. So certainly, I would say as best as you're able to on that day, or as soon after as possible.
Okay, thank you. So this provider is asking, do you need a plan amendment when providing relapse prevention services, or just document that in a progress note?
You can just use a progress note.
Great, thank you. Let's see. Is there a relaxation of program capacity in order to meet the needs of as many individuals who seek the service or who seek services?
I'm not entirely sure if someone's asking about the number of people you can serve in your program from a caseload perspective, or if they're looking at a group size. So that's something we'll evaluate when we look at the questions.
Okay, all right, thank you. And if that individual who chatted that question in wants to clarify, feel free to chat it in and we can also loop back to that. Is the emergency guidance an all or nothing type of guidance, or can it be used for some clients and regular billing used for others?
So this is Peter. I'll say again that we are not precluding providers from billing for individual clients under the existing PROS methodology or the PROS method that that providers have been using up to this COVID-19 guidance. So they may do that for any given client if they're meeting the same time and service standards under the PROS conversion method.
Okay.
I would add in that case, they would not be appending that claim with the disaster emergency modifier, and we would be able to make clear which services were rendered under the traditional contact standards and which clients' services and claims were billed for under these modified billing standards.
Okay. Thank you for that, Peter. Let's see. Will providers still be required to bill U modifiers along with GT 95 and potentially CR?
Yeah, this is Peter again. I believe that the U modifiers will still be required. We'll take that, if we can add that to our compendium of questions, take that back and verify that.
Okay.
I think that's a base modifier. The GT telehealth modifier should be included on all claims where that's the modality of the service delivery.
Okay. We'll also indicate for OMH to take this back and confirm. So another question, if a service is delivered in person and all others through telehealth and existing minimum requirements are met, is it correct that the GT 95 telehealth modifier is added?
Can you, this is Peter again, can you, go ahead. I was going to ask if you could repeat the question. I think the question is asking Sure. If there are some preponderance of the services were rendered in person and some were rendered via telehealth. I would suggest that you would add the telehealth modifier in that case.
Okay, that is the nature of the question, Peter. Yes. Okay, let me just sort through. And again, thank you for everyone chatting in the questions. We've gotten a ton in this short period of time. So I'm just trying to find some that we might not have touched on at all just yet in our question section. Let's see here. How do we, how should providers calculate billing when a person attended PROS normally in person at a point in the month, but then telephonic services were provided later in the month?
This is Peter again. I think that sounds like the same or a similar question where some services have been rendered in person and other services that are being used to meet these minimum requirements were delivered over a telephonic capacity. And I think that we would expect to see the GT or the telehealth modifier added to those claims.
Yeah.
Okay. All right. I think we're getting towards the end of our time. So I want to ask if the state has anything else they'd like to add before we conclude. I am sorting just to see if there's, one last question I can squeeze in, but I just wanted to see if there's anything else the state wanted to add here.
Yeah, I will, if you don't mind. It's Liam, and I just want to say to the PROS community, we've been in touch with many of you and had regional calls, and what you guys have done and your teams have done is exceptional. You've really gone above and beyond, and what we've heard is such innovative and creative ways to connect with people, and so kudos to you and thank you. It's been terrific hearing about the work you guys have done.
And I'll just like to emphasize that, we do have staff available to help with individual billing questions, and we didn't emphasize this mailbox too much. So there is, I think on the last slide, an email that is transformation@omh.ny.gov And that's another resource for you if you have specific questions or questions that you wanted further interpretation on from the webinar.
Thank you, Peter. And thank you to all of our presenters and to everyone who joined. And again, just acknowledging we got a lot of questions that we were not able to get to, and all of those will be shared with the state following this webinar. So thank you for chatting those in. And I hope if there's anything else from the state before I conclude.
Thank you, Meg.
All right. Well, yeah, thank you. Have a great day.